Hello everyone and welcome to episode 14 of season 6 of the Fat Doctor podcast. I'm your host, Dr. Asha Lamy, and today I'm going to say some stuff that you might not want to hear, but I'm going to say it anyway. Weight loss isn't going to help you live longer. I think you probably knew that, but actually there's a lot of things that you're doing right now, that your doctors are doing for you right now, that might actually not help you to live longer either. And drug companies don't want you to know this. Doctors don't want you to know this, because if you knew it, it might put them out of a job. But there you go. Let's talk about preventative medicine. Preventative medicine, like there's two different types of medicine, right? If we can distill it down. There's symptomatic medicine. You come to see me because you have symptoms, and I'm your doctor, and it's my job to figure out what is causing the symptoms and treat you. Like, that sounds pretty obvious, but right? Yeah, you got an infection, I give you antibiotics. You have pain, I give you painkillers. Well, yeah, that's controversial. Let's leave it at that. Problem with your kidney, I address that. Problem, gynecological problem, I address that. It's obvious, right? You have symptoms and they need treating. That's why you're going to see a doctor. But more and more now, you're going to see a doctor for what we call preventative medicine. And that is that you have been diagnosed with a condition or several conditions that are completely asymptomatic. They have absolutely no impact on you in the here and now, but potentially could cause problems down the line. And you know that old saying, prevention is better than cure. So our job as doctors, healthcare professionals, is to prevent that bad thing from happening in the future by treating this condition, this asymptomatic condition that you have right now in the present. So we're going to be talking about that today. That's what we're going to be focusing on. But I'm going to start by saying, in case you didn't know, that weight loss will not help you to live longer. In fact, and you're not going to like this part, weight loss might cut your life short. That's uncomfortable, isn't it? The NHS claims that quote-unquote obesity reduces life expectancy by 3 to 10 years. Jeez. Shaves up to 10 years off your life. That's a fucking decade, man. That's long. So where do these numbers come from? 3 to 10 years. That's very specific. Not 2 to 10, not 4 to 10, like 3 to 10. It actually comes from one particular study, the 2009 Prospective Studies Collaboration paper. It's a whole bunch of bullshit. I want to make it very clear. These people did not study a whole bunch of people and follow them over the course of their lives and see who lived and who died. That is not what they did. They made projections. They created calculations. These were not observations. They were theories. And they were very, very problematic theories because they made a whole bunch of assumptions. So they looked at quote-unquote obesity associated diseases, and they assumed that being fat caused the disease. We already know that's a problem. They assumed that if a person died from a disease that is associated with being fat, then they died because they were fat. There could be all sorts of things, like say heart attacks, right? There's all sorts of things at play here. Blood pressure, family history, genetics. Having rheumatoid arthritis can increase your risk of heart disease. Being on certain drugs can. There's loads of things. Like, hell, having a history of migraines can increase your risk of a stroke. So there's lots of things going on at play. It's never just one risk factor. But they ignored all that shit and just went, oh, a fat person died of a heart attack. That's because they're fat. When a thin person dies of a heart attack, it's not because it's not nothing to do with their weight. When a fat person dies of a heart attack, it's because they're fat. That was the underlying belief that they plugged into their calculation. That was what they were operating. And then even worse, they also assumed that if a person lost the weight, they wouldn't have died. None of that shit is true. That's absolute bullshit. So these calculations, these projections are clinically meaningless. They are absolute bullshit. They are created solely for the purpose of pushing the weight loss agenda. There is no other reason to create this. If a doctor says to you being fat reduces your life expectancy by up to 10 years, you damn well know that you're going to try to lose weight. Like, that is That is the best motivator. Like, I don't want to lose 10 years off my life. Of course I'm going to do something about it. But it's not true. It's a lie. It's based on lies. There's just smoke and mirrors. Bullshit. The most interesting thing is the 10-year thing. Like, the 10-year is a scary one, right? It's a decade. That comes from people who are severely obese. Severe, morbid. You know, people with a BMI over 40. And actually what's really interesting is these people, that I think they collected the data of 900,000 people, almost 1 million people. But the people who had a BMI over 40 were a very, very small portion of that data. And we know that when you're making projections using calculations with very wide errors of margin of errors, then the smaller the data you input into that calculation, the worse the error of margin is going to be, right? They're the least reliable calculations. If you've got a lot of data, you're going to have slightly more reliable. They're still not great, but at least slightly more reliable. But this is like, you know, it's like having a questionnaire, you know, and it's filled in by 1,000 people, but you only look at the results of 10 people. And that's your headline. That's the thing. That's the 10 years. Oh, really? Is that reliable? I don't think so. Yeah, I have a lot of problems with this paper, but the NHS use it. A lot of organisations use it. Whenever you see that 3 to 10 years, specifically that number, you know that it comes from the 2009 Prospective Studies Collaboration paper. What a lot of fucking bullshit. Now, what is interesting is if you look at other studies, you see something very different. So there is the TONE trial, and I forget what TONE stands for, but it's something to do with the elderly. That's what the E stands for. Basically, they got a group of people to lose weight. They lost a lot of weight, the significant amount of weight loss, maintained that weight loss, but it had absolutely no difference in mortality. So weight loss doesn't reduce your mortality. If you look at studies, actual randomized control trials, actual decent data as opposed to the stupid collaboration paper, if you actually look at what the study showed, that's not the case. So the TONE trial is a really good one. There was also the direct trial, well, not the direct trial, so the look ahead study. Again, that one looked at mortality, but it also looked at heart attacks and strokes and found that weight loss did not have any difference, did not impact mortality or morbidity in any way, shape or form. So we can say that with quite a lot of confidence. The question is, does it go the other way? Does weight loss shave years off your life? Not being fat, does weight loss shave years off your life? And that one's harder to decide. I cannot say conclusively yes or no. I will tell you that there's a 2008 literature review that looked at 9 very rigorous studies and found that 3 of the 9 studies showed an increase in mortality following weight loss interventions. 3 out of the 9, so a third. Enough of a concern that researchers said, look, we can't make any recommendations about weight loss based on this, right? Like it's not safe. We don't have enough data. We need more data. So the takeaway from this section of the podcast, this part of the podcast, is very simple. Being fat doesn't shorten your life. That's an assumption built on shaky maths, stupid calculations. But when you actually look at the real data, there's no evidence that being fat shortens your life. Weight loss does not improve your life expectancy. Again, good data to prove that is not the case. Weight loss does not improve your life expectancy. There is even evidence that weight loss, repeated weight loss, might reduce your life expectancy. Can't say for sure, but it's possible. And I don't know about you, but until I know one way or the other, I don't feel comfortable engaging in weight loss anymore. That's the long and short of it. Moving on. I'm going to say something now that's really going to piss a lot of people off. Here we go. There are a number of scenarios, medical conditions, scenarios where fat people have better survival rates, right? They're saying that being fat is bad for you. There's actually a number of times when that's not true. Anyone with coronary heart disease, anyone with high blood pressure, anyone with diabetes, anyone with heart failure, anyone with kidney disease, anyone with dementia, anyone with COPD, in any of those situations, being fat increases your life expectancy. Standard. Fat people have better outcomes after surgery. Fat people, yeah, you heard me right. And when I say that, caveat, There are certain complications that are more common in fat people. Infections and blood clots are the two most common ones. But when it comes to blood loss, when it comes to kidney damage, when it comes to cardiovascular damage, respiratory damage, when it comes to any of those things, fat people always do better. The fatter, the better. True story. Fat people do better in ICU. Yep. I know that we've been told, from a respiratory point of view, that's not true. But when you look at ICU data, fat people do better in ICU. Fat people do better when they're on dialysis. Just a few of the many times that fat people... I bring receipts, there's studies. Now, there are... the way that the medical professional handle all of these phenomena, these kind of massive studies that show, oh shit, actually being fat is better for you than being thin. The way they handle it, as you know, is by calling it a paradox. It is the obesity paradox. It's a thing that it doesn't make sense. Like, we can't quite explain it, but we just ignore it because it's just pretend that didn't happen. Like, we don't know why that is. It's just weird, isn't it? It's weird. That's a really funny way of looking at data that shows that if you're fat, you're less likely to have complications following surgery. Like, you're less likely to lose blood during an operation and need a blood transfusion. If I'm about to have surgery, I'm thinking like, am I going to lose a lot of blood? Hemorrhage is one of the most common complications in surgery. When a surgeon sits you down and is getting your consent for surgery, they will tell you there are a number of risks for this surgery. And I guarantee you hemorrhage is going to be in the top 3. They will say blood loss. As a fat person, you lose less blood. Like, there's so much evidence to support this fact. You lose less blood. You certainly don't lose more blood. So if I'm worrying about hemorrhage, like, actually thinking to myself, oh, but, I'm fat. That's a good thing, right? Because fat people are less likely to lose blood during surgery. That's something I want to know. Why don't doctors say that? Why don't doctors just be real? They'd be like, actually, we've got lots of evidence that fat people don't lose as much blood. So, just say it. Like, you just say it before the operation. Well, that would be nice to hear, wouldn't it? But anyway, instead of doing that, they call it a paradox. And this is the problem. It's only a paradox if you already assume that fat causes harm. Like, if you don't assume that fat causes harm, it's no longer a paradox. It's just evidence. Honestly, I cannot tell you how many times the weight loss industry has funded a paper with the sole aim of disproving the obesity paradox. Like, they're so desperate because this flies in the face of their narrative, right? It's nobody wants to hear, hey dude, if you've got high blood pressure, it's better to be fat. Like, they're telling you lose weight to improve your blood pressure, and here's me going, oh, actually studies say that fat people live longer. Fat people with high blood pressure live longer. Like, it doesn't work, right? So they're constantly trying, but they never succeed. Data is data. Raw data is data. It's very hard to ignore. They'll come up with all sorts of excuses, and you can laugh at every single one of them because the mental gymnastics, honestly, the desperation, they start sweating. Beads of sweat forming on their foreheads. I hate the fact that the medical establishment just doubles down. Instead of going, we thought it was this, but turns out it's this. They double down and they go, oh no, that's just it's a paradox. In real life, fat may, and I'm not saying does, I'm saying may, because I don't have evidence to prove that it does. I have the same standard of expectations when it comes to all evidence. So if you're telling me that weight loss works, I'll be like, prove it. And I have certain criteria that you have to meet for your study to even be worthy of looking at, let alone being thoroughly appraised. Because at the end of the day, if it's a shitty study with a very high, with poor quality study with a high risk of bias, it's not even worth looking at. But I have the same standards when it goes the other way. So I'm not going to tell you that being fat does improve your health any more than I'm going to tell you that being fat doesn't improve your health or worsens your health. I'm not going to tell you that. But there is potentially a protective benefit, especially as we age, of being fat. Because frail people who are thin definitely have more risk than frail people who are, than older people who are fat. Being frail, being thin, does not serve you, especially as you get older. So maybe it's possible that fat is protective. It's certainly not shaming years of your life. But this is the bit that I think is going to really stick in your craw for some people, is that there are studies that losing weight improves your numbers. You know what numbers I'm talking about, right? HbA1c, that's your blood sugar, blood pressure, cholesterol. Maybe people talk about CRP sometimes, although there's not as much evidence, so they don't talk about that. But the main three, the big three, if you were, is blood sugar, blood pressure, and cholesterol, or lipids, right? And we all know that if you improve your blood pressure, if you reduce your blood pressure, reduce your cholesterol, reduce your blood sugar, then that's going to improve your health, right? That's going to mean that, right, in the here and now, you do something about it now to prevent something bad happening down the line, right? Right? I remember being at a conference not too long ago, and I was talking about, specifically about that particular weight loss drug, because people were asking about the weight loss drug. Somebody put their hand up and went, excuse me, how can you possibly say that this weight loss drug doesn't improve your health? It does. I'm here to tell you, I dropped my blood pressure by X amount, I dropped my cholesterol by X amount, I dropped my blood sugar by this much, it definitely works. And I was like, okay. He was like, I've improved my health and I've never felt better, he says. Never felt better. I was like, never felt better? Hang on a minute. This is weird, because you don't feel blood pressure and you don't feel HbA1c and you don't feel cholesterol. You don't feel it. You don't know what it is. Unless a doctor is telling you what it is, you don't know. I do know that the drug you're taking has side effects for pretty much everyone. He certainly for him. Not for everybody. Some people might get away with it and be like, oh, I don't have any side effects, lucky you. But for a lot of people, there are a lot of side effects. You feel that in the here and now. The abdo pain, the diarrhea, the vomiting, the being off your food, the loss of appetite, which is really depressing. The mood changes. The dizziness, the sweating. I mean, there's so many side effects from this drug. And so I was like, because you say you feel better, but why do you feel better? You don't feel blood pressure. And it was fascinating to me. It really was in that moment. I was like, there's a real disconnect between like what you feel and what you feel, because you don't feel these things, but clearly it's making you feel a certain way. And I think that takes us back to our previous episode when we were talking about the placebo effect. A lot of people say, I can feel my blood pressure. They'll tell me I can feel my blood pressure. I'm like, you actually can't. You can't. There's the reason they call it the silent killer. You don't feel your blood pressure. You are feeling something. There's no question about that. I'm not denying your lived experience. I'm not denying what you're feeling. It's not your blood pressure that's making you feel that way. Anyway, that's by the by. I want to talk to diabetics right now because I have the most amount of information for diabetics, slightly less information for cholesterol and certainly for blood pressure. But this is going to really piss some people off. So if you're a diabetic and you live in the UK, and I suspect it's the same everywhere, the current targets are 48, which I think is 6.5%, 48 millimoles per mole. That's what we use here in the UK as a target. And 48 is literally the exact moment where you tip over from not having diabetes to having diabetes, right? Like it is the first number on the scale. So that's the target for a lot of people. We want to get you down to basically not having diabetes. 53 sometimes for some people, but we've got really low targets for diabetics. And if you're a diabetic and you live in the UK or wherever you are in the world, you go to your doctor routinely every 3 months, every 6 months, whatever, and they measure your HbA1c and they tell you it's too high, and then they go, what have you been doing? What have you been doing? Why is it high? Why has it gone up? What have you been doing? What have you been eating? You've not been exercising. I often get, are you eating too many biscuits? Too many cookies for my American audience? That is the assumption. No one ever asks, what's happened? Anything changed? More stress than usual? Getting enough sleep? Are you in pain? Have you changed any medication? All of the actual reasons for why HbA1c tends to go up. If you're not getting enough sleep, your A1C will go up. If you're in pain, you break your ankle or you have arthritis in your hip or whatever, your HbA1c will go up. If you're really stressed out, your A1C is going to go up. No one ever asks you about any of that shit. They just say, what have you been eating? What have you been doing? Tut, tut, tut. Aren't you naughty? Well, we better do something. And they'll tell you to lose weight, obviously. And then they'll go, time to put you on a new medication or increase the dose of your medication or whatever, because we need to get you down to target. We need to get you down to target. The assumption is that the lower the blood sugar, the healthier the diabetic, right? Except that's not true. This is the bit that no one's going to like. It's not true. There's literally no evidence to support that. There's a study that says that there's no anti-diabetic drug that has clearly proven superiority over placebo in reducing actual clinical outcomes. That's not great, is it? Because here's the thing about diabetes. Again, it's like high blood pressure and high cholesterol. It's not doing anything to you in the here and now. If you have very high blood sugar, you will feel it. You'll be thirsty. You'll be peeing more. You'll be getting up in the night to pee. You will be feeling tired. Lacking in energy. All of those things. That's not cool. That's not fun. That nobody wants to feel that way. So symptomatic type 2 diabetes absolutely requires treatment because it's bothering you in the here and now. But if you're asymptomatic because your blood sugar is high but not high enough to cause symptoms, then I'm sorry, but the only reason you know about it is because somebody's doing a blood test. And if that's the case, we're not worried about the here and now. We're worried about the future. Diabetes puts you at risk of issues in the future. When I talk about issues, I'm talking heart attacks, strokes. I'm talking, foot ulcers that end up requiring amputations. I'm talking about loss of vision and blindness, like kidney problems. There's all sorts of things that we need to prevent in the future. Of course, anyone can develop those things, diabetic or not. But if you're diabetic, you're far more likely to develop those things. And so we want to prevent them from happening. But just because we lower your numbers doesn't mean we're going to prevent them from happening. In fact, there isn't any evidence that lowering your numbers is going to prevent those outcomes. And that's a bit worrying, isn't it? Because then you've got to ask, why am I doing it? When improvements do occur on diabetic medication, so there's no one single anti-diabetic drug that has clearly proven its superiority over placebo in reducing actual clinical outcomes like heart attacks, strokes, blindness, amputations, etc., etc. Not a one. Do they reduce blood sugar? Sure. Yes, of course. Otherwise you wouldn't use them. You know they reduce blood sugar because you've seen it for yourself. Does that prevent you from having a serious outcome in the future? No, there's no evidence that it does. Not a single one. When improvements do occur on diabetes medications, so there are certain drugs that have been shown to, say, reduce the risk of heart attacks. It's not very convincing evidence, but perhaps they do. But when they do occur, they tend to happen independent of their effect on blood sugar. So people could be taking the drug and have a lower risk of developing a problem with their eyes, and that wouldn't matter it wouldn't matter what happened to their blood sugar. It worked anyway. Why is that? Don't know. So if you're a type 2 diabetic who feels fine, doesn't have any symptoms, you only know you're sick because you're having these blood tests every few months, yet you're being treated with multiple drugs that have never been shown to improve your long-term clinical outcomes, you want to ask yourself why. There have been multiple studies, especially one in the BMJ, which I will link to the show notes for those who are interested, that have shown with a great amount of certainty that intensive glycemic control, in other words, having very low targets like 6.5, 7, something like that, 48, 53, that there is no meaningful benefit compared to moderate control, which is somewhere between 7 and 8.5 for those who are interested. There's no benefit. So if you have, if you're at 8% and you're like, oh my God, my diabetes is really bad because your diabetic doctor is telling you, oh my God, we've got to do something about this real soon. Actually, the evidence says the opposite. The evidence says, nah, you can stick to it. It's fine. There's no benefit to trying to reduce it anymore. As long as you're well and you're happy in yourself, there's no benefit. In fact, there are risks. There are more risks than there are benefits. There are lots of costs. Because that's the thing, isn't it? Not just financial costs, but actual costs to your health in the here and now. To theoretically prevent something from happening in the future, which apparently these drugs don't do. Or at least having a low target won't do. So why then do they have these low targets, you might be asking? What's the point in having these targets? Why did my doctor do it? Why is my nurse so obsessed with my numbers? Because the people who set the targets are funded by the drug industry, by big pharma, by the weight loss industry. Like, the people setting the targets are paid by drug companies. They all have ties with drug companies. The organisations, the American Diabetes Association, Diabetes UK, NICE, they all have financial ties. NICE not so much, but the American Diabetes Association certainly gets paid a shit ton of money by Eli Lilly and Novo Nordisk and all the other companies that are either selling weight loss or selling diabetes drugs. So that's why, like, the lower the target, the more drugs you prescribe. It just goes without saying, right? And this is the case for cholesterol. This is the case for blood pressure. Like, you assume that it's bad for you, but it's not necessarily true. And this is one of the biggest lies that I expose in the book that I'm writing, is that actually, more often than not, there's no evidence supporting any of this treatment that you're getting, any of this preventative treatment. Forget weight loss, just treating diabetes. Because we are all under the assumption that if we improve those numbers, if we improve those markers, we are going to be healthier, we are going to live longer. But as I said, those markers, you don't feel them in the here and now. It's all about a theoretical, hypothetical, future risk. And these drugs don't do anything about these theoretical, hypothetical, future risks. And weight loss definitely doesn't do anything about those future, hypothetical risks. Because as I said, we've got studies, we've looked at it, we've checked, it didn't work. The only people who benefit from these targets, it's not you. It's not you. You're not benefiting from these targets. The only people benefiting from these targets are the drug companies who are setting the targets, and one can argue the doctors and nurses who have a job to sit here and monitor these targets. If we said, hey, let's do away with targets altogether, which is rather extreme, or hey, we're only gonna we're gonna up the targets, you'd spend a lot less time with your doctor or nurse. And what would your doctor or nurse do instead? Actually, to be fair, we have a massive doctor and nurse shortage. So actually what we would be doing was we'd be freeing up their time to do something else. Wouldn't that be wonderful? I guarantee you that if there were nurses out there who could spend less time seeing diabetics to monitor their HbA1c and could go out and do something else, it's not like they couldn't find a job. It's not like there's nothing else for them to do. There's a major doctor and nursing shortage out there. So the only people benefiting from this is drug companies. And they're the ones that are setting the targets in the first place. They're funding every single organisation. That you will find their fingerprints everywhere. I've talked about this before. There's something called the QRISK-3 score. It is a calculator where you can calculate your hypothetical risk. It's not a guaranteed risk, but it's like a population-based risk of having a heart attack or a stroke in the next 10 years. I do this with all of my clients. I go, come on, let's go and look at the QRISK score. We look at the QRISK score, and it asks you for your weight or your BMI. And I often just put in a random number because I don't weigh patients, but I put in a random number, but basically make the person fat, and then I'll be, that's the risk. And now let's look at the same risk, same person, but all we're going to do is we're going to shrink that person significantly. Oftentimes I'll make them half the weight that they are, right? I'll literally be like, we're going to lose 50 kilograms, put in a different weight, press the button, calculate, and the risk is like, we're talking like 0.3% difference, 0.4% difference. Like, it's something stupid. It's always less than 0.5%. 0.5%. That's the difference between a really thin person and a really fat person. They keep telling you that, your risk of a heart attack is so much higher because you're fat. It's not. It's 0.3%. And you can go calculate it yourself. You don't have to believe me. I looked at the 10-year risk for a person with a normal BMI and a person with a BMI 40, a 50-year-old female, a 50-year-old female with no other risk factors, and I gave them a BMI 21, and then I gave them a BMI of 40, and the difference in their cardiovascular risk was 0.2% in my hypothetical patient. Go figure it out for yourself. Go reassure yourself is what I'm telling you to do. Check out the QRISK. Right. What does this all mean? It means that everything that you've been told to restrict your food, to punish yourself in the gym, to go on, some crazy 800 calorie a day diet, to fast intermittently, to take a tablet or an injection or have surgery. It gets more and more extreme. That all of these things are going to benefit your health because you'll lose weight. And if you lose weight, that will theoretically, hypothetically, prevent something from happening in the future. Whether it's death, whether it's a serious life event, a heart attack, a stroke, cancer, any of the other things. That's what you were told. You were told that if you lose weight, then that was going to prevent you. And I'm telling you, not only is that not true about weight loss, but actually it's not true about a lot of things. That these magic numbers that we're so obsessed with mean very little. They really do. They mean a lot less than we think they do. Even if you're diabetic, imagine, even if you're diabetic, your HbA1c doesn't mean that much. So if you're not diabetic, imagine how little that HbA1c means. So that guy in the conference who was like, I am so much healthier. I feel so much better because my HbA1c is down by 6. And I'm like, okay. I'm sure that feels like a really big thing for you, but it doesn't actually mean anything to me. All of this stuff, it's all based on a lie. Weight loss isn't going to help you to live longer. Your fat body may actually be protecting you, potentially. And the next time someone improves their blood, someone waves their blood work around and goes, look at it, look how good that is. Just know that those numbers mean nothing. And I'm not recommending that you say that means nothing, because that's not a nice thing to say. I certainly didn't say that to that guy. I wasn't about to tell him. I was like, you can figure this shit out for yourself. But you know for yourself that it means nothing. That preventative medicine is really about making drug companies rich and very little else. I'm not saying there isn't any evidence that preventative measures work, because there is. I'm not saying stop all your medications, because that's definitely not what I'm saying. But you can absolutely have a conversation with your doctor about your targets. And next time they go, 7.1, oh, such a bad diabetic, you can go, oh, actually, I'm thinking about increasing my targets to, somewhere like 8, based on this study from the BMJ. See what they say. Have a conversation with your own physician, right? I'm not your doctor. I'm not here to tell you what to do. But you can have that conversation with your doctors, and you can be like, oh, I've read that intensive glycemic targets are of no benefit to me whatsoever, so I would like to have a moderate target instead. I'm not interested in making drug companies richer. I'm quite happy just puttering along, moderately well controlled. As long as that's not going to have any impact on my long-term prognosis, then why should I be making myself miserable and giving myself all these side effects from all of these drugs that, this one causes this and this one causes that, and I can't, leave the house without having to piss or shit. It's not fun being a diabetic, says the diabetic. So you can have that conversation. You can absolutely have that conversation. And you can ignore the other people who are shouting at you that weight loss is going to reduce your A1C, because it really doesn't matter. All right. That's the end of this podcast. The book is available for pre-order. Ooh, right? I'm trying to think. It's available for pre-order very soon, on the 22nd of April. I don't know what day it is today, because I'm recording this in the past, but how exciting is that? Are you going to pre-order it, please? You don't have to. I don't mind. You can buy one for yourself. You can buy one for a friend. You can buy one for your GP. Just saying. Maybe read it first, see if you like it. It'll be available on Kindle and in print. It'll be available around the world. All things. I assume it will be. I don't know. Like I said, I'm in the past. But yes, I'm super excited about this. I'm super excited about next week's podcast episode. I just can't remember what it's about. But it's definitely something good, so you don't want to miss it. Have a lovely week, and I will see you next time.